Our guest is first we have two guests actually. The first one that is going to do some introductory remarks is going to be His Excellency Ambassador Fitsum, who is the ambassador to Washington D.C., the Ethiopian ambassador to Washington D.C. And I would love for him to give a few words of remark. Dear Ambassador, thank you for joining us. And your remarks can be in any language you want, in Amharic or in English. So please, the floor is yours if you can hear me.
Thank you so much, Professor Girma, and everyone. Good morning, good afternoon, wherever you are. Thank you, Ethio-American doctors and leaders from universities, which were informed to be from Addis Ababa University, from Bahar Dar, from Hawassa, Gondar, and Mekelle, for encouraging physicians and medical students to attend this webinar, which will include topics from infection control, safety, to ventilators management, which is really very important in this unprecedented time in the history of the world. We've been attacked by a virus, and I really appreciate the health professionals who are really working hard to defend us all. The Ministry of Health yesterday announced the second day is hurting to see all Ethiopians come together to help one another. Thank you again, frontline responders, doctors, and other health professionals in Ethiopia that will be putting themselves at risk to save life. The Ethiopian government, under the leadership of His Excellency Prime Minister Abiy, has directed us all, including those of us at the embassy across the world, to use our knowledge and network to help Ethiopia combat this virus. Again, thank you, American doctors and those in Ethiopia for all you are doing. አጭሩ በአማርኛ ማለት የምፈልገው በዓለም ላይ እጅግ ፈታኝ የሆነ ወረርሽኝ ገጥሞናል። ምንም ችግር አይገጥማቸው የተባሉ የበለጸገ ሲስተም ያላቸው እንደ አሜሪካ፣ አውሮፓ ያሉ ሀገሮች አቋም የማይችሉት እና አስደንጋጭ የሆነ ነገር እንደሆነ በየቀኑ በመንሰማው እጅግ አሳዛኝ ሞት ባችን የምንከታተለው ነው እና ይሄንን በጀግንነት ለመዋጋትና ለማሸነፍ ህይወታችሁን አደጋ ላይ ሰጣችሁ ራሳችሁን በእውቀት ታጥቃችሁ ይህንን ለመቋቋም እየሰራችሁ ያላችሁ ውድ የሀገሬ ልጆች እጅግ በጣም እንኮራባችኋለን። እዚህም በመንችለው ሁሉ ከፕሮፌሽናሎች ጋር ወደ 35 የሚሆኑ ኢንፌክሽየስ ዲዚዝ ላይ የሚሰሩ አሜሪካን ሀገር የሚገኙ ሙያተኞች ጋር በየሳምንቱ እየተገናኘን ከዛም አጥባጣ ጊዜ እየተገናኘን የነሱን ምክርና አስተያየት ለፖሊሲ የሚሆኑ ግብአቶችን የኢትዮጵያ መንግስት እያደረሰን እስካሁንም ብዙዎቹ ተግባራዊ የሆኑ ናቸው። በቀጣይም አጠናክረን እንቀጥላለን። ያው እየተሰጠ ያለውም ስልጠና እጅግ የሚያኮራ እንደሚሆን ተስፋ እናደርጋለን። ስለዚህ ሁላችሁንም መልካም ስልጠና በመንችለው ሁሉ ሪሶርስ ሞቢላይዝ በማድረግ ወደ 6 የሚደርሱ ጎፈንድሚ የሚባሉ ሪሶርስ ሞቢላይዜሽን ስራዎች እየተሰሩ ነው። እስካሁን ወደ $800,000 ተሰብስቧል በአጭር ጊዜ ውስጥ። እንዲሁም የኢትዮጵያ ዲያስፖራ ትረስት ፈንድ $1 ሚሊዮን ቅዳሜ ዕለት ወስኗል። ካጠራቀሙ $6 ሚሊዮን ውስጥ ለዚህ አገልግሎት እንዲውል ወስኗል። በቁሳቁስም በርካታ ሰዎች በአይነት እየሰጡን በኢትዮጵያ አየር መንገድ አማካይነት PPE የሚባሉትን ፐርሰናል ፕሮቴክቲቭ ኢኩዊፕመንቶች ወደ ኢትዮጵያ እየላከን ነው። በዛሬው ዕለት እንልካለን። አጠናክረን እንቀጥላለን። ከጎናችሁ ነን። በርቱ። መልካም ስልጠና። አመሰግናለሁ።
እግዚአብሔር ይስጥልኝ ክቡር አምባሳደር and thank you ከኢትዮጵያም ጆይን ላደረጋችሁት በሙሉ I'll go straight to the presentation ያው ጊዜያችንም አጭር ስለሆነ ጥያቄ ምናምን ካለ ሁላችሁም በቴክስት ፈንክሽኑ ላኩልኝ እና ለአምባሳደርም ጥያቄ ካላችሁ አቀርባለሁኝ በተረፈ we'll just go straight to the next presentation and to save our time before the hackers hit again. So let me introduce the speaker today. The speaker today is Dr. Rahel Selassie. She is a physician anesthesiologist at Baylor College of Medicine in Houston, Texas. She has taken an active role within her department, serving as a director of patient safety and quality, as well as medical director for anesthesia services in the division itself. She enjoys meeting and discussing questions, ensuring the highest standards of patient safety and quality. And she is actually a well-known educator in this area. And she has joined us to cover the topic that is going to be about quality and particularly safety, and she will probably spend about I would estimate 30 minutes maybe max, and where also infection control and airway management will be the topics she's going to cover. So I have her slides, so I will share my desktop here and in a minute. And Rahel, is there any additional things you want to say?
No, let's get into it. I know we've got time issues, and I do a nice overview at the beginning.
Okay.
Thank you.
Perfect.
Thank you for that nice introduction. You can go ahead and advance. My email is here. We will send this presentation, so if anybody has questions, they can have my address. So we're going to talk at the beginning. This is infection control is very important. It's important because people are anxious and worried about contracting this virus. So at the beginning, we'll talk about how this virus is transmitted. We will talk about infection control on a public level, and then move on to hospital system level. And then we'll delve into procedures that are called aerosolizing procedures. These are procedures that would be done in the hospital that have a very great potential of spreading the disease. We will go into talking about PPE, the proper sequence of putting it on and off, and then move on to airway management, which is usually going to be something that ends up happening to these patients when they come into the hospital with really severe symptoms. Okay, next slide. Can you click on the video for me? Let's see if it works. Maybe not.
No.
Okay. So let's just talk. So the virus, this was a nice video showing the actual respiratory droplets that get spread when a person coughs or sneezes, and it's in slow motion. I don't think it's working, but let's just talk about it. Respiratory droplets are expelled from a person's mouth when they cough, when they sneeze, sometimes when they're talking. And this is the mechanism that is being described as causing the transmission and spread of this COVID-19 virus. So coughing, sneezing, and then if you have contact with those droplets, if you're close to that person, the droplets and the virus becomes viable on surfaces. The surfaces, I mean, it's viable for days actually. And then respiratory droplets are also spread during these aerosolizing procedures that we will come up with. So knowing this, it makes sense then what we're going to discuss next about infection control and the best ways to try to contain the spread. Now, people do still ask questions often about, is this virus airborne? And I will say that according to the World Health Organization and the CDC and the other authorities out there, it is not an airborne virus. Next slide. So we talked about how it's spread. So it makes sense for a general population, if we're trying to worry about infection control and preventing mass spread of this, social and spatial distancing is important. Recommendations, 2 meters is really probably the best advice. Although the WHO has documents that say 1 meter is sufficient. 2 meters is the safest. I'm all about safety, so I'm going to put 2 meters on here. It's very important also to have a really consistent, clear message to the public about really complying with social distancing and spatial distancing, reducing and avoiding crowds, limiting crowded areas that may exist in waiting areas, lines for the pharmacy, in the grocery stores, any other areas where there can be crowds of people, trying to instill and clearly message to the public that it is important to have distance. I know this can be culturally difficult. It's very difficult here in the US to do, but we've seen the success in Europe, and I just want to make sure that that same success is followed in Ethiopia as well. The second most important thing, of course, is basic. It's hand hygiene for all. As healthcare workers, we're used to doing hand hygiene, soap and water for 20 seconds, or using an alcohol-based sanitizer, and doing that all the time. Now, this message has to go out to the public as well. They need to start doing this and practicing this. We call it almost incessant hand washing here. It's a good practice, it's good overall hygiene, and it does definitely help decrease the spread of this infection. The third thing important for general population is creating symptom awareness to really convey and make sure people know what symptoms to be looking for. Now, I know on Friday there was a nice talk by Elias about all of the symptoms. The most common ones are cough, fever, difficulty breathing, and body aches. Those are the most common ones. There are some other, smaller, like nausea. Some other people have some very other symptoms, but these are the common ones. And if we can spread awareness about these symptoms, people can then be aware, self-aware, and then maybe teach them to self-quarantine, keep themselves away from others if they start to feel any of these symptoms come on. Now, there's a spectrum of the severity of these symptoms. It can go from mild all the way to severe, but the moment anybody shows any mild symptoms, it's very important, not for them to run to the hospital, but for them to quarantine themselves at home. Anybody who's also been around that person should also be quarantined at home. And the recommendation is for 14 days, because it can take up to that long for symptoms in these other people to really develop and worsen. Okay, next slide. So hospital infection control, we're gonna start. There's 3 things. On a hospital healthcare system level, the first thing that's really important is triaging and having a system in place where there is early recognition of patients that might be coming in with these type of symptoms, okay? And this early recognition, it needs to be located in a place that is, we say that the facility entrance, because this is one of the key ways to prevent other people from getting infected by a suspected COVID-19 patient, a patient who might have this virus. In this area where it is located, strategically, like I said, it's most effective if it's close to the entrance before patients can have the opportunity to enter your facility. So you may end up having a line at the front of the door as possible. Make sure you still keep the social distancing and the space between patients of about 2 meters during the screening. The person who is doing the triaging needs to do a good job of identifying who's coming in with those symptoms we talked about, the fever, the cough, the real difficulty breathing, and the shortness of breath, and then needs to be highly suspicious that that person might have COVID-19. And once that is determined, then you need to move that patient away from the others in line or whoever's in the lobby, move them away, and then have a designated area somewhere in your facility for those patients. The next best thing you can also do is provide them with a mask or some type of cloth covering that can go over their nose and mouth area, just to cover, so that they won't in turn then cough, sneeze, or do anything that could spread the infection. Another thing that's really important is the signage. If you post signs clearly indicating outside of the building, maybe people with these symptoms, please go to that door. And also it can alert patients they go, okay, well, I have these symptoms, I need to go over there. And it also makes them aware. So signage is also important. All right, now the second big topic for hospital and health system infection control is this overall hygiene. We won't hear enough of this. This is extremely important. Of course, hand hygiene, alcohol-based sanitizer. Again, we need to be doing this as physicians, nurses, any healthcare worker. Washing your hands, sanitizing them between patients when you contact surfaces. Before and after procedures, before and after you even put your personal protective equipment. We need to make sure we're sanitizing our hands. The second component of hygiene is environmental. So this is going to take the support of the hospital system to disinfect all environmental surfaces. You know, the rails on the stairs, the counters where patients may be leaning over and talking. All these environmental surfaces need to be disinfected in a sanitized manner that will disinfect the infection. And then the third hygiene is the respiratory hygiene. Well, so this is when you have these suspicious COVID-19 patients that are arriving at your hospital and are moderately to severely ill, place a mask on them if at all possible. And if you don't have a mask, of course, teach the etiquette about coughing and sneezing. We don't want to do the sneeze that's uncovered because it will just spread the respiratory droplets. So teach people how to cover their mouth with their elbow, use a tissue, or like I said, any type of cloth that could cover the nose and mouth area. The next final thing about hospital infection control is really about the contact precautions and the droplet precautions. You can click again. So keep that 2-meter separation. Use the personal protective equipment. And I put a list here of what it is. So this is a mask, a surgical mask, a medical mask, some type of a face shield or eye protection to protect your eyes, because you think about it, somebody sneezes and coughs and the respiratory droplets are still in the air and they land on your eyes, you can infect yourself. The gown and the gloves. So those are the 4 key parts of the PPE. You need to use new PPE for each patient encounter. Now, I know everybody across the globe has issues with supply and demand. So this is going to be a supply dependent recommendation, but it is recommended that we use a new PPE for every patient encounter. The other thing that has been very effective is instead of having many healthcare workers coming in and out of this separated area where you're taking care of COVID-19 positive patients, if you can have a dedicated team, a limited number of healthcare workers that come into contact with these patients, it does a very good job of minimizing the staff that gets exposed, minimizing transmission risk, and it also does something even more, helps to conserve PPE. If you're reusing PPE masks, and that's how it ends up being with supply issues, and we're reusing PPE masks, then it makes sense to have a dedicated team of these people that are using their own PPE masks again. Another thing to consider on a hospital level is the equipment, stethoscopes, blood pressure cuffs, the things that we use to assess patients and the nurses are using. You can consider maybe not even using a stethoscope. That's been one of the recommendations I've heard. But if you do need to use these things, have it dedicated to the patients in that area. Don't move from the equipment from the COVID-19 patients to the regular patient population. Make sure you're also disinfecting these pieces of equipment. And the last thing is really, I really encourage people to strongly consider having no visitors or family members for these suspected COVID-19 patients. I know culturally this could be maybe a little difficult, but this is really important because you can decrease the transmission risk to the public by telling the family or visitors it's not allowed at this time. Advise these people to self-quarantine themselves if they've been in contact. Okay, so I told you that there were some procedures that are very high risk, which I am very, very strongly recommending we have the proper PPE when these procedures are occurring. This is the list on the left-hand side of the procedures. So airway is one of them, intubating patients, extubating them, doing mask ventilation, doing suctioning, doing non-invasive ventilation, high flow nasal cannula, BiPAP, CPAP, all of those things can aerosolize respiratory droplets and put people around at risk. Doing trachs, also important is CPR, doing CPR. Anybody who's in the room doing CPR is at increased risk. And hopefully you guys are not doing any procedures. We've stopped almost all of our procedures here to save on equipment, but these are a list of some type of surgical procedures that are also considered high aerosolizing procedures. Now this red box on the side is really to really emphasize how high risk these procedures are. You have to minimize the number of people that are there, and it is extremely important if these procedures are occurring that the people who are doing them are properly provided with the PPE, which will include not the medical mask, but the respirator mask, the N95, because that's the thing that will protect them. If you have to reuse an N95, which we are finding ourselves doing that here, we ask that you cover it when you're wearing it with something else so that if any respiratory droplets somehow get sprayed, the front of the N95 is not contaminated and you have an extra barrier or shield with a piece of cloth or a face shield. Next slide. I copied this from the CDC. This is a very nice one sheet slide that will tell you the proper sequence for putting on your PPE and the proper sequence for taking it off. We start with the gown, you put your mask on, goggles, gloves. That's the proper sequence of placing PPE on. Before you do any of that, of course, it's hand hygiene. Removing is done in a systematic way, and the removing is extremely important because you want to go from the dirtiest to the cleanest, and this is to help prevent contaminating yourself as a healthcare worker. So you'll take your gloves off, then your face shield, then your gown, and then finally your N95. Next slide. So I told you that we'd have a dedicated healthcare team, but there is a little bit of a difference between the PPE that's going to be required for the normal daily care, direct patient care for these patients, and the people who are going to be doing the aerosolizing procedures. So I put it in a table format. This is also something really easy, a one sheet thing you can print out. And if you look at it, really the difference is for the aerosolized procedures, you must wear an N95. I can't stress that enough. It's important. Now, the other difference with the aerosolizing procedures, these high-risk procedures, is we really highly recommend putting on 2 gloves. Double gloving is what we call it. So the reason is, and you'll understand, when you're going on the right-hand side here in the doffing sequence, once you have gone into the airway, for example, if you're intubating the patient and you're placing the tube in, your gloves have touched the saliva, the lips of the patient, and so when you're taking off, the first thing we want to do then is just remove that second layer, the outer layer, because that one was contaminated. And the reason we do that is so you don't then turn around and touch the ventilator or touch a syringe or touch anything else with those soiled second layer gloves. You remove them, then you have a clean inner glove, and you can do those other tasks, hooking up the tube to the circuit for oxygen, like I said, touching the ventilator. And then you go through the rest of the process the same way. Next slide. Okay, so intubating is part of the airway management. This is something that will eventually end up happening because patients really, the pneumonia gets so bad, the oxygenation becomes so low, the patients have such difficulty breathing, and intubation is the thing that ends up happening in the ICU. So these are the recommendations for infection control and for safety for the person who's performing the procedure, for the people in the room as well. So we want to have the least number of people around during this time. I say the anesthesiologist or the respiratory therapist, whoever will be doing the intubation, is the one person that should be there. And then also an assistant. Both of those people will need PPE, but the assistant is very important because they can help with doing some of the tasks, like pushing the drugs. They can also be an observer and observe and make sure that whoever is doing the airway is protected and has not cross-contaminated anything. It's important to obviously pre-oxygenate the patient with 100% oxygen. Usually for intubations, we do about 3 minutes. Now we're saying do it for about 5 minutes before you intubate to buy yourself time before they start to desaturate with their oxygen levels. The other recommendation is to avoid doing the mask ventilating. And the way you do that is doing the rapid sequence intubation, very rapid sequence induction, very similar to what we do for somebody who comes in with a full stomach. So you just give the induction agent, whichever it is, if it's ketamine or propofol, and you follow immediately with a paralyzing agent like succinylcholine. And you just wait for the succinylcholine to take effect. It's usually 30 seconds. And then you intubate. The person who intubates needs to be the most experienced person. That's really recommended because you don't want to spend extra time or waste any time, especially when these patients do desaturate. Whatever you feel comfortable with as far as laryngoscopy, you can do direct visual or you can use a video if it's available. Remember to remove those outer gloves immediately after you have placed the endotracheal tube through the vocal cords. And then with those clean inner gloves, proceed with your procedural tasks. And then take off your PPE in the proper fashion. Next slide. So these are just some goals and considerations just to kind of go over. We want the least number of people present. Everybody who's doing these aerosolized procedures or doing any airway management, which includes even suctioning, needs to have PPE. We want the most experienced person doing it. Avoid ventilating by mask and avoid bagging patients. It's also important that when you're doing the induction or extubation, that you really try to give medications and do everything you can to prevent the patient from coughing. So IV lidocaine is something that works pretty well. You can also use narcotics during this time, but it's really important, sedation, paralytics, whatever it is, to prevent the patients from coughing. And then remember, all of these are recommendations. These are all recommendations about infection control, about airway management, but there's nothing that really replaces the person and the physician, the healthcare worker's best clinical judgment in the room. So always remember that. And then stay safe, protect your patients, and protect yourself. I have one more slide, I think. Yeah, so summary. This is just a summary of what we talked about. So the big points are infection control publicly. We need to socially distance, encourage everybody to use masks. They can use homemade scarves, bandanas, agabi, anything they want. Dawood was saying that on Friday. He's very correct about this. It prevents those respiratory droplets from being spread by that person, and it also is protective for the person wearing it as well. The hospital systems need to have a triage system, a hygiene system, and contact droplet precautions in place. The PPE needs to be available for the healthcare workers to protect them. We need to protect the healthcare workers or else we won't have people to take care of patients. Have a dedicated team for all of your suspected COVID-19 patients and the ones that have been proven as well. And the airway management, just make sure for people doing airway management or doing any of these aerosolizing procedures that they have an N95 available and that they use it, and it's critically essential for those people. Everybody else can wear a mask, a regular mask. And that is it.
Well, thank you so much, Dr. Rael, for this nicely succinct presentation. It didn't take the whole hour, so I think we have still some time to maybe go to questions and answers. So in the meantime, I just want to collate some of the questions that have come through the chat room, and I just want to give an opportunity to Dawood to say any additional comments if he has.
Yes, I think most of them will come as a question and answer. Let's do that, and then if we have time, I will say something at the end.
So here is a question from Dawood. It says, do you have special or different ventilation / mechanical ventilator setup that is used for others that have ARDS than COVID ARDS, or I think the question is, are the pathologies and the mechanism, the ventilation mechanism, is it the same?
Actually, that's a really good question, Doug. It is the same. We treat it like ARDS, and that would be low volumes, high PEEP as tolerated, and trying everything we can to keep the patients up as far as ventilators and mechanical ventilation is concerned. You know, the different things I'd say are a lot more prone positioning is happening for these COVID-19 patients. We've seen it's extremely helpful. That's probably really the only difference, but the ventilator settings for ARDS are very similar to what we're doing for the COVID-19.
So there is a question from Sanai that says, there are some patients with coronavirus who had no contact history. How can we explain this? I have come across with corona, maybe airborne. There are some patients with coronavirus who had no contact history, and please explain. So, you know, Rahel, you can take that, or Daud can take that as well.
Oh, that's a good question too. So contact history is kind of sometimes hard to establish, but we do know that people can be asymptomatic and still transmit this virus. That's something that has definitely been happening because we found the same situation here in Europe. They may have very, very mild symptoms, so maybe don't even realize that they had coronavirus at all. And so sometimes that can be explained. Daud, do you have anything to add?
Well, I mean, as you said, we are social animals. We don't know where exactly we are in a daytime. I mean, if you look at where you're going, how many people you're touching in a single day, it is very clear to you and everybody else that you can get infection from very unsuspected source, whether it is in a bus, in a meeting, in an elevator, wherever it is. So it's very difficult. The most important thing actually on this issue is up to now, for example, if you look at Ethiopia, most of the cases, you can actually trace them exactly to a single case who brought it to Ethiopia, which is a very good thing for me. I always am following that information, because the moment you clearly figure out that there are cases whom you cannot trace them back, then that is a definition of community transmission. And that is when you don't know exactly what you're doing and how much you should do, whether it is lockdown, whatever it is. At this time, it looks like it is a measured one. So we have to work really hard not to have a community transmission as much as possible. Eventually it will happen, but in a controlled way, in a very slow fashion.
So, Dr. Theodros, do you have any thoughts that you may want to add, particularly on the ventilator aspect of things that was mentioned, you know, from ARDS perspective? Please, you know, add any of your thoughts.
Yeah, just it has been said that we use the same modality for ARDS due to other cause and ARDS due to COVID. We are promoting low tidal volume ventilation with higher PEEP, and we are giving training actually to the faculty and to the residents here also on that. We have started that, and I think some of our residents are also very good in manipulating the ventilators, and we'll continue with that.
So everybody knows, towards the end of this week, we'll have also two lectures on ventilator management, and hopefully we can go a little bit more in depth about the topic of ventilation. And so we have one relatively basic talk, and then a second one a little bit more specialized talk. So I see Dr. Wondosen Amonye is also online, and I would really appreciate if you can say a few words on the infection control aspect of things, and maybe the challenges you see from your side, just for the sake of a conversation, Dr. Wondosen.
In order to add some, we have a couple of cases confirmed with COVID-19, and we don't know how they got it, because they didn't have any travel history, nor did they have contact with an identified person diagnosed with COVID-19, a couple of cases. So we don't know, but we cannot say there is an established community transmission because we don't test adequately. The testing is very inadequate. So we are getting ready to handle, to take care of the epidemic. And as you all know, we have problems with personal protective equipments, N95 mask, and so on. We are trying to become innovative in such a way that we are trying to prepare some with disposable materials, which we can find in our setting. So we are trying to do our best in terms of providing training, enhancing the infection prevention and control activities and the like. But Kurambasa is not the primary site. It is Eka Kotabe, but as things go, if things get worse, the Kurambasa is going to be the primary site. So we are going to see more and more cases. I had actually a chance to see a couple of cases, We are learning, although it's frightening, but it's frightening.
Yeah.
It's frightening to everybody.
Yeah, so I think this is why we have launched this webinar, so that we can discuss, communicate, and share, ideas and experiences, because it is also serious and frightening on this side of the Atlantic. And believe me, all hospitals are stressed out, both financially, and PPE problem is also true over here. So talking about PPE, for Rahel and Dawood, there is a question from Talane that says, what should be done to reuse PPEs? How do you conserve, or how do you clean it up, or how do you reuse PPE? I know, Rahel, you touched during your talk about the N95 to be covered. Can you reiterate that again, please?
Mm-hmm. I mean, the truth is that everybody, almost all the institutions I've talked to, even on the West Coast and East Coast, we are reusing our PPE. Supply is such a big issue for us. The only way that they will give us another one is if it becomes worn down or if it's physically contaminated. So they've given us a lot of recommendations on how to reuse them. The first thing is to protect it. That was one of the things I mentioned. So put your N95 on. If we're talking about the N95s, you put the N95 on, and then you put a protective coat or layer of something, like I said, a gabi or a cloth. And then when you're done using it, you do everything you can not to touch the outer surface of it with your hands. And then you place it in a brown paper bag. You write your name on the outside of the brown paper bag, and then the hospital system keeps it there for you. And the process, their thinking is the drying of it will help to decontaminate anything that was on the outer surface. And so that's one way we're doing the N95s. We haven't had to reuse anything else at the moment, although I will tell you the regular medical masks, they're asking us not to change them. They want us to wear one medical mask. They give us one in the morning, and we leave it on the entire time we're at work. We don't take it off. And then they allow us to throw that one away. But I'm assuming if you get into the point where you need to reuse a medical mask, you would do something very similar. Try to protect it from getting any splash on it or being contaminated, and then store it in some type of a brown paper bag. That's what we're doing. Anybody else? Dawood, do you want to add anything?
Yes. So we can see them as a surgical mask and N95 mask. For the surgical mask, really, honestly, to tell you, for surgical mask, you can use reusable home-produced materials. It's just basically to cover. I mean, the ones that are being produced in Ethiopia garment factories, I have heard already that there is a capacity to produce about 200,000 a day of those face masks. And I've been showing them some prototypes to produce via cotton. If you can get hand on those ones, I think this would be comparable to the simple surgical mask. And the good thing about it is you can reuse it by sterilizing it in the evening. What you need is a boiling water for 10 minutes, and you can do that. Or if you want, you can dispose it, but there is no need. I mean, that would be the solution for surgical masks. Because surgical masks are so fragile, it would be very difficult to maintain them for a longer period of time. When you come to N95 mask, that's a little bit different. I think the best thing to protect your N95 mask is to use a shield. And I have been, my wife is a nurse, and we have been practicing creating a shield, and it's very easy. If anybody is interested, I can send you a video clip. What I did, it's a plastic. You cut a plastic, and basically you put a small foam at the tip. Can you see me? Can you hear me?
Yes.
Yeah.
Yes.
You just put a little bit of a foam. I have actually a picture after I'm done. I will send you, Girma. You can post it if you want. And then you just create a shield that is reusable for many, many days. So what you do is every time you put your N95 mask, you put that shield, and so it will protect it significantly. And you have to reuse it like what Rahel has said, to put it in a brown bag and for the whole day. The way how you have to take it off is very critical. You always have to take out N95 mask that has been used using while you have gloves in your hands. And you have to make sure that the strings doesn't touch the outside part of the N95 mask when you put it in the brown bag. And when you take it out also, you have to use a gloved hand. So these are the things, even here we're exercising. The good thing for you guys is the peak of Ethiopia is going to be probably about 2 months or more from now. By that time, I think the pressure from Europe and US is going to be much, much lower. So the delivery of N95 mask will not be as difficult. But for now, because you're seeing few patients, this should be what I would recommend. Thank you.
So one thing that factors into this is also the fact that most of the patients nowadays that come to the operating room, for example, for us, are already tested. So we know their status. So I think in the future, once you have, particularly for those who need surgery, once you know their status, if the testing becomes available, that is one of the strategies also to conserve the N95s, because if they are not positive, if you have a good test, then we don't have to use the N95. So that's how we have protocolized, and every time we go to the OR, if this is an emergency case, we have the N95, and then we put on top of it a regular surgical mask. So as described by both Rahel and Daud. So there's one more question that kind of goes to a case scenario. So you are in the hospital, in the chest clinic, patient coming with, with similar symptoms. What do you think we should do? So, to distinguish if this is just a regular problem from, pneumonia or whatnot, is it COVID in this day and age? What should we do is a question from Kalkidana.
We treat, if you come in with those type of symptoms, our criteria is you have a fever, you're having a cough. We ask if you've been in contact with anybody who's known that they've had COVID-19. So we ask about travel history. And then based on the answers, we err on the side of caution, and we will go send them for a test. We'll still keep them separate from other people, but we order a test.
Girma, just to add on that, until you know there is a full-blown community transmission, it is a challenge to answer this question. But I just want to plug in there. I'm sure Wendosen and Dr. Tedros knows this, but if you don't, I want to tell you that the EPHI is telling us that they will test every suspected case from a hospital. They have a capacity. So take them on that, because last time I asked them, they had only 27 or 30 cases that were sent from hospitals. We have to send hundreds and hundreds of cases for two reasons. One, it will really give us a good perspective in terms of if there is any community transmission that we are missing. But the second most important thing is it will help you for the infection control, because their turnaround time is as good as ours, 1 day at most. So because of that, for 1 day, you can isolate those patients. And then after, in a day, since your results is out, you don't have to waste PPEs after that. So this will be a very helpful thing. One thing that EPHI and Ministry of Health are doing is they're just doing community surveys on high-risk patients. There is a lot of controversy on that. I don't want to go into that, but it is more helpful than not doing it, because we just want to know what is going on in Ethiopia. Because if you look at even Djibouti tests more per day than us. I mean, it's just annoying. Kenya tests like 10 times more than us. I don't know what their guidelines in terms of the testing criteria is, but if you're going to test 10 times than us in Kenya, you have to be testing people who don't have symptoms. Otherwise, they don't have a lot of patients to have a symptom and high risk exposure. So you have to test, figure out exactly what's going on in your country. If there is none, then we don't have to worry about every upper respiratory tract infection that we see in our clinic.
So the message there is, until ruled out, you need to really be, caution should be on the thing that's most important. So the next question, which I can try to answer, is what is the experience on the shifts that physicians do during the day and how many hours? So I can tell you from, even the surgeons, in our hospital are now in that COVID-19 mode. And so what we have is we have our teams separated in two groups. There is a day team and a night team. Each team covers 12 hours, and we go on 5-day blocks. So we start 7 a.m. to 7 p.m. The night shift takes on at 7 p.m. and finishes at 7 a.m. And we do this for 5 days in a row. And then another team comes and takes the day shift, when those who are in the day shift will go to the night shift. So that's how it is being done. And actually, there are, so you can be off for 5 days. That off doesn't mean you'll be going home and sitting at home. It means just you will be on a regular clinical duties. So this is a very serious pandemic, and it's like almost considered like war. And everybody has to be in this together, and everybody has to really be actually volunteering to help. At the end of the day, we are physicians. We have to take care of the sick, and we cannot abandon them because there's this pandemic. And so we have been actually working on these shifts with our internal medicine colleagues. And believe it or not, I think I'm scheduled, for example, to take a 5-day block time in the critical care unit as a tier 2 physician, meaning I'll have an intensivist above me who is handling actually 3 teams. And I'll be one of the physician leaders with a group that has a resident and a physician assistant and nurses. So this is how we are doing it, and I know for Ethiopian condition, it's going to be probably something you have to design your own. However, you have to also be careful about screening and making sure people who may be at a higher risk not to be involved in these exposures. And that high risk group definition might be also very locally defined, but you can also follow the literature in terms of comorbidities and whatnot. So, Rahel, maybe you can share how you do the shifts in your clinical practice now, covering COVID units.
So it's similar. The concept is it's a week on, and then they want you an entire week off. And the reason they want you off is because they want to determine if you develop symptoms, any symptoms from being exposed. And then we are able to do, we do urgent cases. We don't do any electives, but we're doing urgent cases. So on the urgent cases, when you're coming in, you can come in and do that. But the 7 days that they want you to wait to see if you develop symptoms, I think is something nice that they've done, because they don't want to continue to expose others.
Hi, my name is Dr. Zarihun Bunai. I'm a critical care physician. I'll be giving lectures on the ventilator management. So the things I wanted to say, I think answering from the pathophysiology and the ventilator management, we're still learning about the COVID-19, but what we have seen so far, this disease acts in a different way. Right now, the thought is there are two classifications of or types of the disease. They call them type L and type H. So the L1 is more a compliant lung, or which is not, it doesn't act like ARDS. But this can later on, through the course, can change into ARDS kind of lung. And the other one is right away, you would see a very wet and non-compliant lung, which is the typical, ARDS pattern. So I think you have to individualize your ventilator management. It's very interesting, what we see here, especially the type L ones, they will come, you look at their chest x-rays, like very, very little infiltrates, at the periphery, or CT scan is very, very subtle infiltrates, and they are on the bed, I have like 4-5 patients last night. I was, in EICU watching them, all of them are on 100% non-rebreather, and they are on the bed, they're watching TV, they are comfortable, are not in distress. But the minute they move or turn, they will desaturate. So, you could call those patients, and if you look at the peer pressure and so on, you could call ARDS, and you may end up intubating, but we are watching them, and some of them are improving. So these are the kind of patients whose lung is compliant. On the other end, some of these people progress into the ARDS or the wet lung type. So for those, you manage like ARDS. So with the things that was mentioned earlier, including low tidal volume, high PEEP and so on. Different. If you end up intubating those patients who have a long, a good compliance, you should be careful not to add a lot of PEEP, and also, use a lot of positive pressure in general. And, some of the things which are observed are like, if you use, even CPAP, you should just try it only for a short time and, intubate them, but, do not use a high PEEP. So what I wanted to say is, you have to individualize the patient. You have to look at them. The ARDS patients, usually you'll see them struggling, huffing and puffing. These other ones, they just look comfortable. They are just sitting there, but they are hypoxemic. They are on non-rebreather. They are talking to you. Their organs are preserved, but they are hypoxic. They don't have any reserve. The simple turn, they will decide that they will come back. You just watch them, and if they are unable to maintain their oxygenation with whatever oxygen you have given them, then you may try CPAP. I know it's aerosol generating procedure, but you can try for a little bit, and then maybe for an hour, then you go ahead and intubate them. But again, you limit the pressure. You don't use the high PEEP in these guys. And some of the physiologies from the pathology postmortem examination then shows their pathophysiology is like microthrombosis and so on. So you have to individualize your management. What I'm saying just for the work schedule in my hospital, when I work days, I work 7 straight days. It's usually a 10-hour shift, and night I do between 4 and 3 nights. So I don't do 7 straight nights. Thank you. So that's all.
Yeah, thank you. This is also a preview of the ventilator management that's going to come towards the end of the week. And thank you, Dr. Zarihoun, for joining us from work. And looking forward to your 2 talks on ventilator management towards the end of the week. So for everybody online, there is a question about waste management of COVID patients, be it stool or urine or other contaminated materials. Is there anything new from waste disposal perspective, Daud, people should know?
I don't have anything right now specific for COVID other than any infectious hazardous hospital waste. But this is a very interesting thing. So what we would do is we'll look into what we're doing here. And as a guideline or as a protocol, we probably would share it with the Ethiopian team.
So there is, I think this question came up because Rahel said that you stay with your PPE for the whole day. So somebody, I think it says in Jerusalem, is asking, so you say you are with PPE all day, how do you eat? How do you go to the bathroom? And, what do you do?
That's funny. Okay, I say all day. I mean, they won't give me another one, but no, I don't wear it to go to the restroom. I take it off. The point is, I must put it back on. Normally, when I would go to the bathroom, I would or when I leave the operating room, you just immediately discard everything before you even walk out. Is usually what they want you to do. So now that's not the case, is what I'm trying to say. We are reusing things in a way that would have gotten us in a lot of trouble with our regulatory agencies. But I do, of course, take it off when I go eat and I go to the restaurant.
So there is a very important concept that everybody should know, that in this kind of disaster situations, there are things you need to talk in different spaces. The spaces are, the S's are staff, because you need the people who are going to take care of the patients. You need supplies, which is the other S, which are basically like the N95s and others. And then you need the space, meaning you need to have an area where you're going to put this patient. So this is really something from disaster medicine in general. And in that category, you have a lot of strategies that you have to use, and one of the strategies is conserving, and reusing PPEs is part of that strategy of conserving. So Dr. Theodros, I want to give you a chance to also talk a little bit about this spectrum of ventilator management or patients, clinical conditions that Dr. Zerihun touched upon. If there is anything you want to add to that.
Okay, thank you. I think Zerihun was talking about the spectrum of the disease, as we have most of the cases are reported to be mild, but there are also moderate cases, those with mild pneumonia, and then those with, most of them, they respond to oxygen of different level and with different devices. So I was talking about that. These are viral pneumonia, mostly viral pneumonia, presenting with severe manifestations. Then they can either, you can titrate up or titrate down the oxygen. And finally, the RDS is, I think, even though we know that there are said to be different types of RDS, but RDS generally, they either respond to high flow oxygen, which is very, in only limited number of patients, but majority or almost all of them, they require intubation. So probably he was talking about the patient probably a little bit earlier stage. Otherwise, those RDS, even though there are some types or varieties, but those RDS cases, if we label them, I think they need ventilation. Thank you.
No, thank you. And then Dr. Wondosan has asked, how soon do you get results back? And I think that question varies from an institution to an institution. So when we started testing patients here at the University of Wisconsin, initially took about 4 days or 5 days, because we had to send it to an outside lab. But right now there's a company that's actually that produced the tests here in town, and the results were coming in about 6 hours, 8 hours, but now for our inpatients, we have the results back in 2 hours. So I think it's improving continuously, and I'm sure, Dr. Wondosan, for you guys, it might be probably a lot more than a day, but that's how faster and faster it's getting in terms of assay. I don't know if Daud or Rahel have anything to add?
No, the time, the most of the time is on logistics and collecting the samples actually than the test itself. So for example, the Ethiopian scenario, they batch it in 30 specimen, I think. So they have to wait until 30 specimen are collected and then after transported to PHI at least at this time, and then after run at the same time. But otherwise the test actually takes about 4 hours even in Ethiopian setting. But overall, when you look at this, it takes about a day. But it's not really longer than any other place. A day would be what you would see in terms of turnaround. So I don't think that is the big issue. The big issue is the number of tests that we are doing, because all those questions about PPE and protection and personal protection comes into play once we have really a meaningful grasp at how big the problem is. If you do thousands of tests and there is no COVID in the country, and the test is really as good as it gets, you know, it's a PCR test, which is approved by WHO, and all those control measures have been tested in the Ethiopian setting. So we have to rely on that. And if you do thousands of tests in the community or high-risk patients and then none is found, I mean, you have to be cautious as usual, but it is not going to be as critical a dire as when the community transmission is going to blow.
Well, I think before we end the session, I just want to say one thing about this rotation, because the rotation of healthcare workers or the shifts, because there's multiple questions that are being raised. I think it is definitely important for, you know, AAU or other places to define your own system. But I think what we have embarked on is, number one, can we use a minimum number of people to be exposed to this problem? Because at the end of the day, you also don't want to run out of, you know, people getting sick or whatnot. And so with that in mind, I think the number of people we want to engage or involve in a day has been reduced to a minimum. So that's why we have the 12-hour shifts. You know, some places do it for 5 days and other places do it for 7 days. And these are in the critical care unit. So I think this is a very common practice here. It will conserve you more people, and it can really keep people going for a much longer period of time, because you don't know how long you're going to have this problem. And so I hope that answers that repeated question about rotations in the critical care unit. So with that, I just want to really thank, you know, everybody for joining in and listening and also asking questions. And I really appreciate you guys being patient with our initial technical challenge that we had. Extra thank you to Rahel for this wonderful presentation today. And thank you, Dr. Theodros and Dr. Wondosen, for joining from Addis and being part of this conversation. And I really appreciate also both Zerihun as well as Daud for joining from the US and participating in the conversation. So, and thank you again, everyone.